start, sir.
A very good evening to all of you, and thanks for joining us today on this platform of Department of Urology, SMS Medical College, Jaipur. So, in the continuation of our teaching program, today we have a class on augmentation urethroplasty, a step-by-step approach. So, this technique will be presented by our own resident, Dr. Naveen Vaishnav, and this will be moderated by our professor, Dr. Nachiket Vyas.
Hello.
Today we have three special invitees with us. I will just tell their names after we start with a Saraswati Vandana. So let's start our session with Saraswati Vandana. Just
नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा.
Thanks, everybody. We will start today's session. Today's session is on augmentation urethroplasty, a step-by-step approach. It will be presented by Dr. Naveen Vaishnav, our resident, and moderated by Dr. Nachiket Vyas. We have three special invitees today with us. Dr. H.S. Bhatyal. Nobody needs any introduction to Bhatyal sir. He is a very senior urologist. Thank you, sir, for coming. He's a very senior urologist. He was an army person, and he started in army way back in 1990, PCNL and renal transplantation at that time. And he now is the head of the department at BLK and Max Super Speciality Hospital in Delhi. He started a transplant center in Delhi also, and also in one of the other countries like Tanzania. That's very creditable. And he has a lot of innovations to his credit, the instant SPC code through. And he has been also our past president of North Zone chapter of Urological Society of India. And about the extracurricular activities, he is an ardent golfer. So thank you, sir. Thanks for coming to our platform. And next invitee is, thank you, sir. Thank you. Next invitee is Dr. Ranjan Kumar De. Dr. Ranjan Kumar De is a professor of urology in a medical college which is my own alma mater, that is Archikar Medical College, Calcutta. So Ranjan Da is senior to me, so usually I call him Ranjan Da. So Ranjan Da, you are most welcome to our department. And he has been also the honorary secretary of Bengal Urological Society. He has been convener of the MCH course, and he has also been an ex-council member of Urological Society of India. Most welcome, Dr. Ranjan.
Thank you, Shivam, for your invitation. I'm fortunate that you have called us in this August gathering to be a part of your academic extravaganza.
Thank you very much, sir. And we have Dr. Amit Kotiar, who is again a very senior urologist. He hasn't probably joined. Dr. Amit, have you joined? So he is a senior consultant, is working at a private hospital in Jaipur. So we welcome Dr. Amit Kotiar whenever he joins. And then again, we have many very senior urologists who have joined us today. And we are really fortunate to have them, like Dr. P.N. Dogra sir is there, Dr. Kochar is there, Dr. Anurag Yadav is there, as I see. So we have so many stalwarts of urology. Nachiket, you are really very fortunate to have all these people today with you. All right.
Sir, I think that I'm not fortunate. All of us are fortunate.
Right.
And today we have a gold mine of experience with us. And I think that we have the three best minds for this session. And our residents are going to immensely be benefited by the knowledge that they are going to get from Bhatyal sir and Ranjan Kumar De sir and Amit Kotiar sir, three urologists that I personally have looked up to since my residency days, and I have seen them and the quality of work and the knowledge that they can impair to the residents, it is, as I said, the weight in gold. So I request the residents to take full advantage of their knowledge and their experience. And again, special welcome to P.N. Dogra sir, the teacher of teachers, and Kocher sir, and also Anurag Yadav sir. And he has come to our teaching session of the department for the first time. I am sentimentally very close to him. He is from my hometown. And again, I have looked up to him as from the days where he a very successful urologist himself, and he's been very active in North Zone. Welcome everyone. And without now wasting a further second, I request our resident, Naveen, are you there?
Yes, sir, I'm here, sir.
Yes.
So Naveen, you can start your screen sharing, and then I'm going to hand over the presentation to Naveen. It's a very concise presentation. This is because we wanted more of a discussion of our residents with the stalwarts. And Naveen, you can start sharing your screen, please.
Yeah, sure, sir. So, good evening, teachers, seniors, colleagues, and juniors. Today's webinar topic is augmentation urethroplasty. So first is introduction. What is augmentation urethroplasty? It's the augmentation of urethra due to a stricture of various length, which is generally not amenable to some other techniques like dilatation, OIU, or end-to-end urethroplasty. And here we will use autologous tissue like graft, flap, and there are some acellular materials like collagen are also, which are made by bioengineering techniques. Ideally, if we have put the SPG, as patient may present with the retention, if we have put the SPG, it is prudent to wait for 6 weeks to 3 months, as there may be proximal extension of the fibrosis, and this is the most common cause of recurrence. Indications of augmentation urethroplasty: in the bulbar urethra, stricture length of more than 2 to 3 centimeter with spongiofibrosis and BXO changes. In some literature, it is mentioned that we can go for up to 5 centimeter via end-to-end urethroplasty, but it should be towards the membranous urethra and not towards the distal urethra. In pendulous urethra, stricture of more than 1 centimeter with spongiofibrosis, with BXO changes, or with fossa navigularis stricture. And the other indication is pan-urethral stricture. Conditions affecting the surgery: first is length of stricture and how much narrowing is there. The more length of the stricture, the more lengthy flap or graft we have to take. And the narrowing, this is the most important part. If there is no complete obliteration, we can go with the onlay technique. If there is a long segment stricture and focal obliteration, then we may need to excise and go for augmentation, anastomotic urethroplasty. And if there is long segment of obliteration, then we may proceed towards a double facet urethroplasty or 2-stage or multi-stage repair. And the presence of spongiofibrosis, density, and the depth of stricture. This is important, as if there is more spongiofibrosis and dense strictures there may be less vascularity and less chances of take of the graft. If there is any infection or fistula, we may think for 2-stage repair. And previous instrumentation, surgery, history of radiotherapy, redo surgery, vascularity, this all will affect the take of graft due to decreased vascularity. And one more important thing is presence of lichen sclerosis. It is important because here we will try to use the graft rather than flap, as chances of recurrences are high. Bleeding sites, more common bleeding sites are part are bulbar artery, urethral artery, venous sinuses, or from the bulbar and the scar excision or transaction area. Various techniques are, we can use various graft and flap, as I have discussed earlier. The graft can be taken from oral part, that can be buccal mucosa, lingual mucosa, and labial mucosa. It can be rectal or bladder mucosa. It can be post-auricular, full thickness skin graft. Flap we can take from penis, prepuce, and scrotum. There are some acellular matrix, collagen matrix, intestinal submucosa, and tissue engineered material. Different techniques are, we can use single or double stage, as I have discussed in case of redo surgery, radiotherapy exposure. In single stage, we have dorsal onlay or inlay technique, ventral onlay or inlay, lateral onlay. combination of dorsal only with ventral inlay, or opposite, ventral only with dorsal inlay, or both side dorsal and ventral only. We can have non-transecting urethroplasty. We can have augmented anastomotic urethroplasty. And for two-stage repair, we have Johnson repair, Schritter repair, Brackus, and Kulkarni's modified two-stage repair. For panurethral stricture, if there is lichen sclerosis, we have Kulkarni's penile invagination technique with dorsal BNG only. And if there is no lichen sclerosis, we have various flaps and grafts like mechanic and Quartis technique, Asopa's technique, and various only techniques. We will be discussing it one by one. So in pre-op preparation, we will get anesthetic fitness. We will control the comorbidities. There will be part preparation, mouth gargle if buccal mucosa or oral mucosa graft is anticipated. Mouth gargle should be started. Antibiotic shot covering the, it should be broad spectrum, and the consent of on the planned procedure and other possible procedures. The sutures we use is Vicryl or PDS 4050 or 60 for urethroplasty and 30 or 40 for spongioplasty. Position will be low lithotomy or extended lithotomy. First exposure technique. After calibration, we will give a midline vertical incision from perineoscrotal junction up to 1 centimeter from the anal valve, and we will deepen it. We will cut the Colles fascia, peribulbar fat, and then the bulbospongiosus. And once again, we will calibrate. We will get the distal extent of the stricture, and if SPC is there, we will get the proximal extent of the stricture also. Then, depending upon the procedure, we will either completely mobilize the urethra from perineoscrotal junction to the obliteration level or slightly beyond it. This depends on the technique. In cases of dorsal only, we will mobilize. Inlay technique, we won't mobilize. And then we will get hemostasis. We will prepare the graft bed. We will prepare graft and then do according urethrotomy, either dorsal, ventral, lateral, or combination. So first, how to retrieve oral graft. This is the most common that we are doing, buccal mucosa graft. So I will go with detail in detail with buccal mucosa graft. So oral graft are buccal, labial, and lingual. Here we will prefer anesthesia, general anesthesia with possibly nasal intubation. We will put roller gauge piece in the pharynx and retractor to wide open the jaw. Then there we will mark the extension duct with the marking pen. We will take a stay suture at the angle of mouth just inside the vermiform body. We will inject xylocaine 2% with adrenaline of approx size of the graft will be approx 2 to 2.5 centimeter wide and length as per need. It will include both superficial and deep lamina. Immediately after taking the graft, we will put it in the saline gentamicin solution and defatting of graft will be done. In tobacco chewers, one can use lingual graft. For fossa navicularis reconstruction, we can take labial graft as well. Benefits of buccal mucosa graft: it is easy to access, easy to harvest, obviously hairless, it is durable, full thickness, and there is less chances of contraction. It is viable in wet environment. It is well vascularized and adapted for new vascularization. And it is advantageous in lichen sclerosis. Donor site complications can be hematoma, infection, ulcer, pain, or extension duct injury. We can close or keep open. We can close the donor site or we can leave it open. It depends on surgeon to surgeon. Both have merits and demerits. If we will leave it open, there can be pain, ulcer, and delayed oral intake. And if we will close, there can be hematoma, infection, and if there is tension duct injury, we will diagnose it late. This is diagrammatic representation. In the first diagram, we have shown the stay sutures and extension duct, and we have already injected xylocaine and 2% adrenaline. Graft has been marked. It is taken, and below the two diagrams are the donor site after taking the graft. We can close it, we can leave it open. Now dorsal only technique, Barbagli's technique. Now in the previous slide, I have explained the area, the perineal area is already exposed. We have prepared the graft bed and we have taken the graft. Now we are proceeding towards the dorsal only technique. We will put the graft over the corpora cavernosa with mucosa facing towards the lumen, and graft is well spread, and then it will fix to the corpora cavernosa with lateral sutures and also the quilting sutures. The edge of the corpus spongiosum, where we have given the incision in the urethra, in the dorsal side, dorsal urethrotomy or stricturotomy. Now the edge of the corpus spongiosum will be sutured to the buccal mucosa over 14 French elastic catheter, and each stitch incorporates underlying corpora cavernosa, the buccal mucosa, and the corpora spongiosum. All three should be covered. Advantage of Barbegli technique: there will be less blood loss, and there will be interrupt adaptability, more surrounding structural support we have, so less dribbling, UTI, and impaired ejaculation chance. But the disadvantage is disruption of surrounding microvasculature and challenging visualization if we have to proceed proximal, and dissection is closer to the membranous urethra. So in first diagram we have calibrated, and in second we have given the proper exposure, and we have marked the distal extension of the stricture. This is complete mobilization in the, and then the graft has been placed in the corpora cavernosa. It is fixed and with quilting sutures, and the catheter has been placed. This is the lateral border of the stricturotomy part, and now it is covered over the buccal mucosa. The wound is closed. Next is Kulkarni's technique. This is similar to Barbegli technique with few modifications. There will be single-sided urethral dissection. And the idea behind is that we can preserve the one-sided neurovascular bundle at least. And there will be one-sided mucosa to mucosa and other side mucosa to spongiosa suturing. And the third difference is if there is panurethral stricture, there will be penile invagination, so that we can repair all the stricturous part with one incision only, on that is on the perineum, not on the penile area. And the advantage is preserved blood supply and improved take with single incision. Now ventral onlay. It is in the bulbar region that urethra lies slightly dorsally towards the corpus corpora spongiosum. It is possible for us to use the buccal graft as ventral onlay, but the prerequisite is we should be having adequate amount of spongiosum tissue to cover it. Its advantage is minimal dissection, easy exposure, and robust blood supply. But the disadvantage is more blood loss will be there, less surrounding support we will be having. So there are more chances of diverticulation, fistula, UTI, ejaculatory issues, and dribbling issues. In the first diagram, we are showing this is complete exposure of bulbar urethra. This is the extent of the stricture, and this line is marking the ventral urethrotomy incision. We have given it, and now fixing the buccal mucosa in the ventral onlay fashion. And here we have given the spongioplasty coverage. Next is lateral onlay. Here the tissue in the lateral side, the tissue is slightly thinner, so there will be less blood loss along with the good structural support. Now coming to inlay techniques, ventrally placed dorsal inlay technique, that is Asopa's technique. Here we will give the ventral urethrotomy, and then from here we will go towards dorsal side. We will give the incision over the stricturous part, and we will place the graft from this area only. So we would not be mobilized the complete urethra, and of course the graft will be buccal mucosa. But here the prerequisite is we should be having at least 1 centimeter wide urethral plate. With and the maximum chances of augmentation is up to 1.5 centimeter. This is a super technique in the penile urethra. After degloving, we have given over the stricture ventral urethrotomy incision. This is the dorsal part. We have given the incision. We have placed the graft and then close on ventral side, and this is coverage of this. Next is combination techniques, means dorsal inlay with ventral onlay, that is known as parliamentary technique. Its advantage is, as we are putting two grafts on both sides, one in onlay and one in inlay fashion, we will have the maximum chances of increase in caliber. It is easy to expose as we will be putting onlay in the ventral side only, and there will be preserved microvasculature, and preserve plate and vascularity, it will avoid sexual dysfunction. But the main disadvantage will be more graft material would be used and more than one urethrotomy is done. Now opposite to it, now the Gelman technique, dorsal onlay and ventral inlay technique. So here we will give the dorsal urethrotomy and dorsal onlay BMG, and on the ventral side we will excise the scar and put the graft in the bed of excised scar over ventral spongiation. It will also provide the wider lumen. So this is about the grafts. Now I'm coming about the flaps. So flap harvestment can be done with penile, scrotal and preputial areas. And the ideal flap will be non-hairy, e-piloted skin, healthy, well-vascularized and non-infected. It is better to use in onlay fashion, and sometimes we can tubularization can be also be done. It can be used in penile and bulbar stricture both. And for scrotal skin, the disadvantage is it is hairy and there is tendency to shrink and there is unilateral blood supply. So I am describing one by one the different flaps. First is the Jordan flap. It is ventral, longitudinal, vertical flap on the penile skin. It is used in onlay technique after inversion. This is Jordan's flap. Orandi's flap. It is again ventral longitudinal penile flap used in onlay fashion. It is ovoid flap, but the difference is it can be having lateral pedicle, which will be using in lateral urethrotomy, or there can be ventral pedicle, which will be using the ventral urethrotomy. Next is mechanic flap. There can be mechanic flap is complete preputial or penile fasciocutaneous circumferential flap. If the patient is circumcised, we will use distal penile flap, or if uncircumcised, we can use preputial flap. The width would be 2 to 2.5 centimeter and length can be up to 15 centimeter. Division would be done on ventral side and used after 90-degree rotation. Here it is wise to know that for skin, for flaps, we should not go beyond 2 to 2.5 centimeter width, as there can be diverticulation after the urethroplasty. Next is QWERTY flap or hockey stick flap. It is combination of Orandi's procedure with that of mechanic procedure. That is preputial as well as penile flap. And it is a wide and large flap. It can be used for panurethral procedure. We have some dorsal flaps also, like the Kett's flap. This is Turner-Warwick procedure. It is again ventral longitudinal flap, hexagonal, but it is having bilateral pedicle, and it can be used in penile and bulbar stricture both. So complications of penile flap will be loss of penile skin necrosis, disturbed sensation, pain of bending on erection, and as I have already explained, it is not suitable for BXO due to chances of recurrence. Hair growth can be there in the urethra and diverticulations. Now multi-stage repair. The indications are complex stricture with extensive scar and infection, fistulation, and prior multiple failed repairs, totally obliterated residual urethra, and post-stage radiation. The different types are Johansson repair, Schritter repair, Bracas repair, and Kulkarni's modified repair. Augmented anastomotic urethroplasty. Main indication here is previously failed urethroplasty or long traumatic strictures with focal near obliteration. That part has to be excised, and then after incision on the residual urethra, we can have the strip anastomosis, that is known as floor or roof anastomosis on the other side. One side is anastomosis, and on the other side there will be augmentation with the BMG. Post-operative care, the vitals and comorbidity will be managed. Drain removal can be done at the third day if there is no collection. Maintenance of hygiene and dressing is of utmost important. Avoidance of constipation. PUC should be removed after 3 weeks after MCU, and SPC should be removed after 7 days of PUC removal. It is clamped if it is already there. And regular follow-up if symptoms persist for cystourethroplasty or RGMC or uroflowmetry. The complications are wound infection, wound dehiscence, bleeding hematoma, and neuropraxia or venous thromboembolism. And the delayed complications can be recurrent strictures, urinary fistula, and graft necrosis and failure, erectile dysfunction, and donor site complications. Thank you, sir.
Yes, Najib.
Thank you, Naveen. Can you stop sharing your screen, please, Naveen?
Yes, sir. Yes.
Thank you, Naveen, for this very concise presentation. Actually, we could have had a longer presentation, but the whole purpose of today's meeting was for our residents to interact with our consultants or our invited faculties. And whatever questions you have, you can ask our faculty. And in the meantime, I'll start off with a question for all the three invited faculty that we have, sir. When Bhatyal sir and then Ranjan sir, and also Kotia sir to help me out. So when do you decide to do a dorsal onlay, and when would you decide to do an inlay or a Nasupa technique inside, say, exactly the same length of stricture of urethra inside the penile and the bulbar region? When would you do these two techniques? Do you have any particular patient in which you want to do this method, and inside a particular patient you want to do this method? Dr. Bhatyal sir, and then Ranjan sir. Sir, you are muted. Sir, can you please unmute yourself? Sorry.
Yeah.
Yes.
Sorry. In a case which is, for the first time surgery, and if the caliber of the urethra is about, say, 12 French, you have to have at least a 3 millimeter of the urethral strip on both sides if you want to do a SOPA technique. I would rather say that a SOPA technique should be limited to little smaller strictures rather than the pan-urethral strictures, number two. And the same case if you want that, well, which case will you take as a dorsal onlay or a dorsal lateral onlay? If the caliber of the urethra is a little smaller, as your resident said, 1 centimeter. 1 centimeter is a little too big a caliber for the stricture of this repair. I would rather say you should have at least 3 millimeters of strip on both sides. So 6 millimeter, because you have to roll it around. And if you don't have a strip, you can't roll it around. In those cases, you should go for dorsal or lateral, or where you find it may be difficult to roll over the two edges of the urethra to tubularize it.
Sir. Ranjan sir, your comments?
First of all, I like to mention that the augmented urethroplasty is basically, it is a combination of excision and substitution. Excision and substitution actually gives us the definition of the augmented urethroplasty. It is mostly effective for the management of the bulbar urethral stricture. Now, with the size of the bulbar urethral stricture is the determining factor. If it is less than 2 centimeter or less around 1.5 centimeter, still the resection anastomosis is the treatment of choice. But nowadays, for the preservation of the sexual activity and the other complications, we can go for non-resecting urethroplasty. In this case, and if the stricture is more distal towards the bulbar, then I will definitely try to do it as a dorsal onlay, because here the spongiosa thickness is less, and if it is more proximal, I will try to do a ventral onlay when the corpus thickness is more. So we can change our decision only at the time of the operation, finding out where is the exact site of the urethral stricture, and accordingly we can decide what procedure we will do.
Can I add one thing?
Yes, sir. Please, sir.
Yeah. See, the thing is, a SOPA technique you talked about, and the dots and other way of doing it. So we are limited ourselves to this thing. A SOPA technique should be limited to the pendulous urethra, I personally feel. Coming to the bulbar urethra, we have other techniques available with us, as your resident already mentioned. So in penile pendulous urethra, a SOPA technique can be useful. And the difference is only between the SOPA technique and if you want to mobilize the urethra, maybe dorsal only or dorsolateral only. That's what I wanted to say. But one point very important to all the resident and everybody. There is a difference which people are not addressing it properly. What is the difference between augmentation and substitution?
Yes.
There's a misnomer. It's a misnomer. It has to be rectified. All these procedures, what we do are the augmentation procedures. Substitution is the procedure when you do not have a uterine plate and you want to create a new urethra, that is substitution. You don't call a bladder substitution as a bladder augmentation. Augmentation is different. Bladder substitution is different. Okay? Mammoplasty, memory substitution is different.
Exactly. Just like the substitution of a player on a football team. I mean, he has to be removed and then he has to be totally substituted.
So it's a misnomer. It's a misnomer.
Shivam sir wanted to say, sir, so please continue.
Sure.
There is something, slight confusion with augmentation urethroplasty and augmented anastomotic urethroplasty. So what we are talking about is the augmentation urethroplasty and the different techniques of augmentation urethroplasty. And sometimes it is also confused with substitution, as Dr. Bhatyal said. Only one thing that I wanted to make a point is Dr. Bhatyal said that it is not good. The Ossopa's technique is not good for if you extend it to the bulbar urethra. It's only for penile. That is probably not explainable in the sense that it could be for something which is that you at least have to 6 or 8 millimeter wide strip so that you can put a flap in between. But the length would not probably matter whether it is Ossopa's technique or a dorsal only technique. I think we have been doing with the Ossopa's technique all pan-urethral strictures. And Nachiket, you know, we have been doing, you also have been doing. So I don't think that is a hindrance for Ossopa's technique. Yes, please.
Yes, I think Bhatyal sir wanted to make a comment, and then we'll take comments from our third invitee, Dr. Kotia. Bhatyal sir, please continue.
Dr. Kotia is
why I said for bulbar urethra. You know, the bed to the dorsal inlet Ossopa technique is given by the capital bodies. And as the capital bodies separate, you do not have a good bed there in the mid and the proximal bulbar urethra, whereas you have it in the distal bulbar urethra. I have made myself clear. Thank you.
Okay. Sir, I don't think that we have Dr. Kotia, sir. I think, has he joined us?
He's probably not joined, yes.
So, as I'm the moderator of the session, will you give me permission to add Anurag Yadav, sir, for his comments? This is because I have a bias because he's from my hometown and is just like an elder brother. And sir, Dr. Bhatyal says that we should be very, doing Ossopa very limited inside penile urethra. So, being from Agra, would you like to rebut or would you agree with him?
Inside bulbar urethra.
Yeah. I think it is good for penile urethra, and I would not do it for pan-urethral strictures. But as far as bulbar strictures are concerned, doing a onlay, lifting the bulb, will also have the same bias. Like you do not have a base, you do not have a bed for your graft. So while you are doing it by ventral sagittal hysterectomy or by lifting the bulb is always there. The proximal and the mid bulb, you do not have that bed, but you have to fix it to the perineal membrane or the tissue between the crura.
Sir, would you do it for a long penile urethral stricture, the Ossopa technique?
Yes, but not,
you would do it.
Not pan-urethral.
Pan-urethral. Ranjan sir, one question, and then I'll come to Shivam sir for some comments. Is the number of suture lines in Ossopa technique a concern for you? This is because you're dividing the urethra dorsally, you're dividing the urethra ventrally, placing the graft, one suture line on the left, one suture line on the right, then you're closing the urethra in the midline. Is that a concern, and what is your experience regarding Ossopa's technique of urethroplasty for anterior urethral strictures?
I am telling you, with this, in my small experience, the chances of impotence, the impotence is much more because the arterial supply and the venous drainage and the circumferential vessels, if we cut too many times, then if you suture it, the blood supply of the urethra, which may not be adequate, and that can give rise to more sexual dysfunction especially in the younger patient. So I preferably not to do this.
Which one?
Shivam sir,
Asupa or dorsal?
Yeah, I want to do it dorsally.
Dorsally. So Asupa's technique would probably least compromise with the blood vessel, because the blood vessels come from the lateral side on the two sides. So probably that would be it. That's a very valid point. Only thing is, Dr. Bhatyal said, if you can put a dorsal only in a bulbar urethral stricture, then there is no way that you cannot put by Asupa's technique also. So it's the logic remains the same. Anyway, Dr. Bhatyal,
so
yes.
Bhatyal sir, he wanted to make a comment, and then Neeraj has joined us, and Neeraj would also like to make a comment. So first I'd ask Bhatyal sir. Bhatyal sir, can you unmute yourself, please? And then Neeraj can ask a question.
You see, the difference is when you do dorsal or dorsolateral mobilization, you have a good dissection. You have good anatomical display of the place where you want to put the graft. When you do a SOPA technique, it is only separating these things, and the dissection is not that good. And I said up to proximal bulbar urethra, you can use it, but I would not like to use it for the mid and the proximal urethra. Up to distal, you can use it. I will not like to do it for the proximal and the mid.
Okay.
What Dr. Asopa says, he says that I am not lifting the urethra, I am not dissecting any side, neither am I dissecting the right side or the left side. I am just dividing it in the midline. I am keeping the neurovascularity of the urethra intact. So that's why, as far as vascularity and other thing goes, my technique is more sound. This is because I am least, touching the normal anatomy of the urethra. This is a comment that he made inside a personal communication. Neeraj is with us, and Neeraj is associate professor of the department, and he does an excellent urethroplasty. I've seen him personally, and I'm impressed with this. Neeraj, you wanted to make a point, Neeraj, please.
Yeah, boss. Thank you, boss. I was listening with interest regarding the discussion on Asopa and dorsal onlay. Sir, one of the issues, I don't have much experience about Asopa's urethroplasty, but for the handful of cases that I have done, what I have realized is that the width of the buccal graft is an issue when you do an Asopa's urethroplasty. I mean, when you do a dorsal onlay, just like a Barbagli, either you completely lift it, or as Dr. Kulkarni does it, a dorsolateral with one-sided mobilization. I think you can take a sufficient width of the graft and then, suture it to the spongiosum on one side. But the limitation in Asopa's technique, I think, is first of all, there is a limit to which you can mobilize the dorsal urethra on both sides, number one. And number two, here you have to suture it mucosa to mucosa on both the sides. So that way the width of the graft becomes a concern. And I think in my view, it is only applicable if you have a sufficiently wide urethral plate, number one, and if the length of the urethral stricture is short. So I think, correct me if I am wrong, I would like to hear it from the experts about their opinions.
I personally also agree with Neeraj that it should be used for the small segment urethral stricture for this purpose, not in the whole length pendular urethra and all.
This is what I also stated.
Right, sir. Sir, one question that the residents frequently ask, and I think that they are asked inside the exams, and I think that as examiners, sometimes we do not give them a concrete answer. What would be the success rate of the buccal mucosal graft urethroplasty, the long-term success rate, and the intermediate now results are out? So what do you think? This is an open question for all our invited faculty, including Anurag Yadav sir and other faculty also. Bhatyal sir, what success rate would you like the residents to quote in terms of a good flow without any intervention, without the need for additional procedures? What would the 5 years success of a buccal mucosal graft for a long anterior urethral stricture be?
70 to 75%.
Totally agree with you, sir. Ranjan sir?
60 to 70%, most of the time.
Totally agree with you, sir. And Yadav sir?
Yeah, I think 80%, because you have said 5 years. But if we
Yes.
go longer, maybe 10 years, more of the cases will fail.
Okay, sir. So I personally feel that the success rate, the long-term success now would hover around 60 to 65% without any intervention. It's not as if we have multiple papers and we see multiple presentations in fora in which the claim is 95%, 97%, 90%. I totally do not agree with those tall claims, because ultimately I think that around 60 to 70% of patients, they fare well. And I think that is the true data that the resident should state, that the long-term 5-year success of buccal graft would be to the tune of around 65 to 75%, maybe. Absolutely. Shivam sir, I think that you can take the discussion forward from here, please.
I have a small question for the resident.
Yes, please.
I have
Yes,
a small question for the resident. That in the post urethroplasty period, how do you follow them up? How do they follow them up?
Naveen?
Yes, sir, I'm here, sir. Sir, please, can you repeat the question, sir?
Sir is asking a question. Inside the post-operative follow-up, how do you follow our patients of urethroplasty?
Sir, clinically as well as with investigation, I will call the patient after the everything, the sutures out. After that, if follow-up, I will ask the patient to come in the 3 months or early if there is any symptom. And with symptoms, I can be prudent enough to ask for any further investigation. And in the clinical part, I will ask the questions about the flow and all that symptoms which were previously there. If the patient is still bothersome, then I will go for ultrasound KUB with PVR. I have to know the post-void residual volume, and if need, and uroflowmetry. And according to that, we can again go for RGMC. And if there is no symptom, then again at 6 months I will call for if there is any symptom.
At what time do you remove the catheter? At what time do you remove the catheter?
At 3 weeks, sir. If everything goes well.
After that, you call the patient at 3 months or before that?
If there is any problem, then we can call early. I will explain the patient if there is any problem. You can come anytime.
What problem do they expect? What you want them that this can happen? What problem? Which is the commonest difficulty the patient face after removal of the catheter?
Sir, pain. Dysuria and pain.
Dysuria and pain. Anything else?
And the recurrence of previous symptoms. Any of them, sir.
Now, in the lower urinary tract symptoms, which is the commonest is asked?
Commonest, yes.
You know, there are voiding symptoms, there are storage symptoms, and there is another more symptom. Which is that, Naveen?
Sir, about obstructive lobes, sir.
No.
Hesitancy and
symptoms, unit symptoms, there are voiding, storage, and there is a post-void dribble.
Yes.
So that post-void dribble is the commonest with augmentation urethroplasty.
And
right?
that you should warn your patient that this can happen. Otherwise, they get scared that after the surgery I have become incontinent. So this is a particular thing I was asking, because such thing we face every day. Anyway,
yes. Dr. Ranjan, you've made a very, very valid point. I think that's the commonest problem that these patients would have. Almost 25% patients would have some post-void dribble. Yes. Yesterday we had a session with Dr. Kulkarni, Pankaj Joshi, and Nikolaski also, and Dr. Ganesh Gopalkrishnan was also there. So we had a wonderful session, and there they said that the results, as they say, is 85% in their hands of augmentation urethroplasty and 5-year follow-up. Anyway, so Dr. Nachiket has asked me to continue with the debate.
Sir, I just have one last question for all the invitees, right. Patyal sir and Ranjan sir and Anurag Yadav sir. What after a good urethroplasty, the patient is satisfied? What are the good flow rates that you get in uroflowmetry? This is because usually we do not get the characteristic bell pattern that we get inside after an end-to-end. This was, I believe, that basically you're just making a conduit. So what are the flow parameters that you're looking for after the management of a pan-anterior stricture? Patyal sir and the other invitees to follow. Patyal sir. Sir, you are muted, sir.
For me, if he maintains his maximum flow rate at 16 plus and his average flow at 18 plus, I am happy with that. If he continues to have that thing, because but of course, in bulbar urethral stricture with a good repair, you may be able to achieve maybe 20, 80 or 18 or so. But in otherwise, a pendulous stricture urethral repair, 16 French if I get 16 flow rate if I get maximum flow rate, I'm happy with that.
Okay, sir. And Anurag Yadav, sir?
Yes, I think 15 is okay in strictures, and it is not like after 2 hours. 2 hours, you have a very good flow. In the strictures, especially if the pan-urethral stricture was there, because initially there is some edema or some tightening of the glands, and of course there is some recurrence at the meatus in most cases, especially buccal mucosa. In the initial few weeks or months, buccal mucosa shrinks in a way, and you have to somehow do a self-dilatation if you have taken it to the meatus. So I think flow rate of 15 is okay, but I personally in the follow-up do not ask for flow rates. I straight away go for calibration, and my routine is I call the patient 1 month after removal of catheter, and I do a calibration myself, and I pass a 14 French Foley's catheter. No dilatations, no stiff catheters, only a Foley's catheter that will go only if the urethra allows it. And a 14 going easily means an 18 French urethra, because in a 16 French urethra, 14 will be quite snug. In an 18, it will go easily. So a 14 French goes, I'm happy. Then I call him after 3 months, then 6 months, and 1 year, like that only. And if the patient does not need any dilatation, I call it a success. And I don't say that I'm doing any ancillary procedures. It is only an investigation that I'm doing by calibrating by a Foley's 14.
Right, sir. Ranjan, sir,
Yes,
one thing that I wanted to ask, one thing, sorry, I wanted to, if you, in your comment, if you can add this, that the curve pattern that we get is usually a plateau type. We never see the characteristic bell curve. And kindly want your comments from that.
Absolutely, I must say that I may not be, I am not so efficient. Normally, we get a flow pattern, maximum flow pattern at 12 to 13 in the post urethroplasty. And
I totally agree. Yes.
that is what we get regularly. And another thing I would, Professor Dr. Anurag Yadav was telling, but I am asking the audience or the senior members, what do you think the success of a urethroplasty? What do you mean? At what point you should consider my urethroplasty successful?
Shivam, sir.
Yeah, actually, we had quite a good discussion yesterday also about that. And Dr. Kulkarni and they told me that post-operatively they follow up only with the patient's symptoms, and they would not do in every case even a uroflowmetry. So, and Dr. Ganesh Gopalakrishnan also said that it is not necessary, because most of these patients post-operatively may not have a good flow in the terms of maximum flow rate. And if the patient is not bothered, is comfortable with his urine flow, and we should not be bothered about his uroflowmetry much. So at times they are saying that even the flow is up to 10 ml per minute maximum flow, and the patient is not bothered, we may not intervene. Because many times what happens when you do a VIU in these cases with a small stricture, the stricture would even further aggravate, rather than, so he would have a flow of 5 ml after that VIU. So he was saying that the most important thing is whether the patient has bothersome symptom or not. If he is bothersome with his flow, urine flow, and particularly if there is pain, dysuria, as Dr. Ganesh Gopalakrishnan said, this is probably the most important symptom, which should tell us that, yes, these patients may require further intervention in the form of either a redo or a kind of endoscopic intervention. So, so flow rate may not be very good in these patients after augmentation urethroplasty. That was the take-home message. Yes, Dr. Bhatyal, please. Dr. Bhatyal.
Answer to Dr. Ranjan's question. As Dr. Shivam said, we follow them up like this. Everybody knows how to follow them up. I carry out a visual flow rate. You ask the patient to pass urine in front of me. And if I find that patient's flow is okay, he's fine. Second thing is, why you don't get a good flow rate on your recordings? Because this is a non-compliant urethra. It is not the same urethra as the normal urethra. The students must know this thing. You can never reproduce a normal urethra after urethroplasty. It has been tampered with. So you will not get the same classical pattern of uroflowmetry in these cases.
Exactly, exactly. Very nice. You would not get that kind of maximum flow rate as after a TURP or sometimes even after end-to-end urethroplasty. And
Yes.
next, the other point that you raised, that is we are usually doing in most of our patients of hyperspadias also. And what I intend to do is in urethroplasty also, ask the patient to get a video clip of their urination, micturition flow. So
Right.
in hyperspadias
Right.
also, what we do, we ask the patient to have a video clip of the child passing the urine, whether there is a fistulous opening or not, or everything we will be able to know with that video clip. So I think that's a very pertinent and a very kind of good way of following up these patients by doing a video. Yes, Dr. Ranjit.
Yeah, I like to know how many of you or how often you ask the patient to do CICS, clean intermittent CIC. Yeah.
No.
Well, we don't.
Not routine.
If it is a successful case, if he has no problem, there is no CIC.
Yes.
CIC, in fact, has got no role. In fact, whenever
Yes.
you say that you require
That's
CIC,
what
it
I
means
wanted
there
to
is
emphasize.
some degree of failure is there.
Yeah.
So you have to address that issue. Either first you do a uroflowmetry and then you do a urethogram to see whether he has got a restricture at some stage or other.
Rather, it is more important to do a urine culture, especially in substitution urethroplasty, to follow them up whether the patient is having infection associated with it in the post-op follow-up instead of doing CIC. That's what we follow and in our hospital accordingly.
All right, exactly. Only those patients who are having some strictures in the follow-up may be followed up either with a CIC or a dilatation or a VIU or a redo urethroplasty. So these are the different options that we have if the patient develops a stricture with bothersome symptoms. One more thing that the chat box also has is about the ejaculatory problem. That also should be counseled to the patient. There would be a semen pooling because the ejaculation would not be in spurts, because the ejaculation in spurts is due to the bulbous spongiosum muscle and even the corpus spongiosum, which is there around the normal urethra. So the semen will not forcefully be ejaculated. It will be pooled sometimes and it may dribble after ejaculation. So that's again a very important point that has been raised, and it has to be counseled to the patient. Now let's go to, I have just made a few points about the controversies in augmentation urethroplasty. We may discuss one by one. Bulbar stricture urethra. If it is a bulbar stricture urethra only, would you do a dorsal only or a ventral only? Yes, it's not just a proximal. It's not just distal. It's a bulbar stricture, slightly extending into distal, slightly extending into the proximal also. Dr. Bhatyal, please.
Well, I think this question is a little confusing. You say bulbar, it means it's complete bulbar stricture. What you mean is it's complete bulbar stricture.
Yes, both proximal and distal.
Yeah, if it's a complete bulbar stricture, I would rather like to do a dorsal onlay and assess the spongiosum. Assessing the spongiosum is very important. Yesterday when you were discussing, I put this thing in the chat box, it couldn't be answered. See, whenever you open up the bulbar stricture, you must assess the spongiosum. If you find the spongiosum is in a good shape, almost near normal, then you're very happy. And when you mobilize the urethra, you may mobilize it to dorsally or dorsolaterally, open it up dorsally and see if on the radiological studies, your stricture was too tight, and you have opened up the urethra, then of course you can modify it by dorsal onlay and ventral inlay. That is double face urethroplasty. Okay? This is for the complete bulbar urethra.
No, so how would you know exactly the corpus spongiosum if you're trying to do a ventral only? If you're trying to do a ventral only, you will have to incise it and then see, right?
No, I'm doing a dorsal only, I told.
Yeah, so
I told if it is a complete urethral bulbar urethra, we'll do a dorsal onlay. But if you want a ventral onlay, I normally do ventral onlay only for the proximal bulbar urethra. And there also you can find out the nature of the spongiosum. It is in front of you. You open it up, and it is easy to put a ventral this graft here in the proximal bulbar urethra.
All right, right. Any comment from Dr. Ranjan and anybody? Yes, Dr. Anurag, I would say comment. Yes, Dr. Ranjan, please first.
The question was, how should we treat a bulbar urethral stricture?
Yeah.
So it all depends what is the length of the bulbar urethral stricture we are expecting. From radiological assessment, we can make some idea what is the length of the bulbar urethral stricture and what is the narrowing extent of the narrowing. But unless we explore, we cannot find out exactly the condition. We'll have to assess the, after dissecting the urethra dorsally from the corpus spongiosa, we'll have to assess exactly the condition of the corpus spongiosa. Depending upon the length of the stricture, if it is around 1 centimeter, we can straight away go for resection anastomosis, because that ultimately gives the best result unless the patient is very young. In that case, we'll have to, considering the other sexual activities and all, we may think of graft situation, non-transecting, urethroplasty, all this. But if it is more than 1 centimeter, 1.5 centimeter, that case, in true sense, the dissection substitution urethroplasty would have been the best instead of giving this small support. That case, we can do a proper mucosa to mucosa anastomosis at one end, either roof or at the bottom, and the rest of the defect has been covered with buccal mucosa, so that it is preferably the dorsal buccal mucosa only will give me the best result. That is how we practice in our hospital.
Thank you, Dr. Ranjan. Dr. Anurag?
But Shivam, you asked for a complete bulbar stricture.
Yeah, I'm
right?
Yes, right. So this is probably the second part of my debate. I would just go ahead with the second. So this was not my this part. Yes, Dr. Anurag, please. Yeah.
Yeah. I would go for a dorsal onlay, and in certain cases only ventral onlay, like in post-URP strictures, and also very short strictures in very young males, where I would also do a retraction of corpus of the muscle, not the division of the muscle, only retraction of the spongious muscle, bulbous spongiosus. So that is very important in unmarried or very young males, because to preserve the ejaculatory function, the muscle has to be preserved. And I would just retract, and you will be surprised to see that even the mid bulb, distal and mid both, can be easily approached by retraction only of the muscle and not division. So for young, ventral with retraction muscle, and for others, dorsal, except for post-URP strictures.
All right. Yes. So the next part controversy was, as Dr. Ranjan said, is a short bulbar urethral stricture, which is almost near obliterative. It's not obliterative, but near. It's quite a narrow stricture. So whether should we do a excision anastomosis, end-to-end anastomosis, or augmented urethroplasty, or kind of a non-transecting anastomosis? Dr. Batial, please.
Yeah, I'll tell you one thing. Number one, it all depends whether it is very well known, traumatic and inflammatory. For a traumatic stricture,
it's a non-traumatic. We are discussing non-traumatic here.
Okay, we are discussing inflammatory strictures.
Yes, non-traumatic.
Okay, if it is a very short stricture, you can do a strictureplasty. Though I have not been good in these things, to be very frank with you, people do advocate that you can excise that part of the stricture urethra from the dorsal approach and bring mucosa to mucosa together. That is strictureplasty. It is meant only for a stricture which is 1 centimeter, less than 1 centimeter. And if it is longer than that, it should be opened up dorsally with a good spongious tissue. As I earlier said, you put a dorsal onlay and excise the fibrous tissue from the this is spongiosa from within, and put a small graft in the this thing, that is ventral inlay. That gives a very good tubularization of these strictures. And it is meant for the longer strictures also. For transection, I would never advise for inflammatory strictures in the bulbar urethra. Yes, but if it is a stricture which is extending onto the distal bulbar urethra and to the part of the penile urethra, that is the site where if there is a complete obliteration of a segment, you can mobilize the complete bulbar urethra by taking it out from the perineal body. The people claim as 3 to 4 centimeters, but in my practice, I have seen not more than 1 to 2 centimeters can be gapped. So you do a anastomotic urethroplasty in these cases, either a dorsal the floor strip or the roof strip, whatever it is, and put a graft on the opposite side. These are the methods available for the bulbar urethra.
Right, right. So in your experience, probably you would be doing more of an augmented rather than a kind of end-to-end urethroplasty. Another thing which was put in the chat box also, another option is an augmented anastomotic urethroplasty. So if the stricture is slightly more than 1 centimeter, 2 to 3 centimeters, then you can even do a augmented anastomotic urethroplasty. On one side, you can make a mucosa to mucosa anastomosis, and the floor can be augmented with a buccal graft.
That's what I said, Shivam. That is why we normally practice.
Right, right.
But the very important point is that you have to mobilize the bulb from the perineal body.
Yeah.
Then only you will get the.
If
that's very important.
Going more proximally, yes, definitely.
I have a comment to make about this, sir. So yes. It's always discussed in all forums. It's always asked inside the exams. As far as I remember, about non-transacting urethroplasty, especially for short bulbar urethral strictures, it was first of all presented by Aldrich in 2012. And till date, I am yet to see a randomized trial which is, being done in between a transected urethroplasty and, a non-transected mucosa to mucosa and anastomosis. So I think that it's high time that a small randomized trial can be done. This is because this seems to be the quintessential question that is being discussed everywhere. But still, I don't remember. I have seen retrospective analysis. I have seen all types of analysis, but a randomized trial, especially for these kind of strictures in the bulbar urethra, is still, I think it's still wanting in literature. So maybe in association with other departments, if our department can do a trial, it will answer the question. I have one question to all of the invited faculty. Primarily, when would you use a lingual mucosa and not a buccal mucosal graft? Is there any chance where you think that, okay, even though the buccal mucosa seems healthy, but I'll go for a lingual graft in this? Is there any subset of patients, Dr. Bhatyal sir, or do you think that no, if you have the buccal graft available, you'll always use the buccal graft?
No.
The most important thing is that if you have already used the buccal graft once, I would rather prefer to use the lingual graft. That is number one. And number two, of course, you all know the contraindication for the buccal graft. You have all problems inside the mouth.
Right.
Any patient would take precedent if both of them they have not been used. If both of them they are available in good condition, is there anywhere that you would take a lingual graft and not a buccal graft? Any precedent?
Those who play that blow instruments,
okay,
especially their cheek restriction will constrain for their profession. In
so that
we can
professional consideration.
Professional consideration.
Right, sir.
That's a very good
or
point.
Any previous surgery that has been done in the cheek for other condition. These are the two conditions where we can think.
Or you are not able to open up.
Yeah, mouth.
You are not able to open up adequately because tongue can be pulled out, and to some extent, I won't say that much, to some extent. But if you're not able to open up the mouth completely, you still have to open the mouth.
Yeah.
All right. So
have we answered your question,
Nachiket?
Perfect, sir. Perfect.
Just one point. That
absolutely, sir. Absolutely. I totally agree with all of your points. All of your points are well taken. And the very important point has been made by Ranjan, sir, that if there are professional considerations for the patient, like if, as he said, if you use an instrument or that is one thing that should also be taken by the residents in history, that what is the profession of the patient. That also, is important during the history taking. Sir, exactly, sir. Yes.
One point, Dr. Shivam, one point very important in bulbar urethral strictures. When they are asked a question, it is given in the literature that you can mobilize the bulbar urethra and bridge a gap of about 3 centimeters, 5 centimeters. I do not agree with that at all. Now, if I ask a student, you have mobilized the bulb from the perineal body, then what prevents you from pulling it up? They must know that their bulbar artery is there. They are still intact. And if you try to pull them too much, there are chances of causing ischemia. So you have to be very gentle. So a gap of only 1 to 1.5 centimeter can be bridged. I think a gap of more than that, it is questionable.
And more of that, there may be caudy. If you pull it and anastomosis, there will be caudy during erection. There will be painful erection also if we do the anastomosis under tension.
I beg to differ because caudy is not a subject of bulbar urethra.
Right. Caudy is more problematic with penile urethral strictures.
No, but if you excise 3 centimeter of bulbar urethra, ultimately the pull also come towards the penile urethra also, because you will have to detach it from its attachment to bring it close.
Right. We have experience with the end-to-end urethroplasty where we excise a good amount of tissue and then close it with end-to-end anastomosis. Usually the caudy is not a problem there. So if you extend it into the penile urethra, definitely it would be a more problem.
That's what I'm telling, because you may have to extend if it is a distal stricture.
Right. So another point that Dr. Ranjan made is very nice about buccal and even for lingual graft. For lingual graft, the problem is sometimes the speeches get slurred. So that if the patient is a singer or has a profession of singing, so probably lingual graft could be a problem in these patients. So the point that was trying to make is once in our department, almost I think about a few years back, 10 years back, we were very fond of doing lingual grafts, and we did it routinely instead of doing a buccal graft. And we had done almost presented this also, and it was published also in the international journal. And our finding was that the lingual and buccal graft has almost equal efficacy. It doesn't make much of a difference whether you take a lingual graft or a buccal graft. The advantage of taking a lingual graft is that we can take the harvest is quite easy. We can do it under regional anesthesia. If patient is under spinal anesthesia, we can just pull out the tongue, give local anesthesia, and usually the patient doesn't have any problem. You can harvest the graft easily under regional anesthesia also. And it's an easier way of harvesting. Even a resident doesn't have a problem of harvesting a lingual graft. And even then, whether you close it or don't close it, the results are quite good. Even without closing, we have taken bilateral lingual grafts. Bilateral lingual graft, and still it has been very well epithelialized, and the patient didn't have much of problem. So I think a lingual graft again is something that we, particularly in our Indian scenario where people have a habit of tobacco chewing, almost 60-70% cases, though they may not have obvious submucosal fibrosis, but still I think they do have some problems with their cheeks. So I think a lingual graft is a very good option in these patients. So that was again one of the controversies that I was trying to make, and that has been, I think, as we have already discussed.
Can I just, have an opinion of the house, sir, regarding Shivam, sir?
Yes, please, Neeraj. Go ahead.
Yeah, regarding the use of lingual grafts vis-a-vis buccal graft. So whatever the literature may quote, but throughout the world, sir, the use of buccal graft is generally more prevalent as compared to lingual graft, and that is because of certain reasons. Number one limitation is that you can harvest extra length of the buccal graft, which sometimes is a limitation in lingual graft. Plus, the thickness of the buccal graft is always more than that of a lingual graft. And it is said that the submucosal or the submucosal plexus, which helps in the uptake of the graft, it is more in buccal mucosa as compared to the lingual mucosa. I don't know what is the general practice of our invited faculty. Maybe we can have their opinion as to their choice of lingual versus the buccal. But as of now, in our department, I think we are using most of the times buccal graft only, and in very limited circumstances, we are using lingual grafts.
All right. Neeraj, we were using a lot lingual grafts.
Yeah, in the past.
But anyway,
I agree,
we can ask our faculty also, and that's actually what I told you is buccal is the, I think, preferred by most. But what I'm saying that lingual should be investigated, should be we should do more studies with lingual graft also to know exactly what is the difference. Yes, Dr. Anurag, please go ahead.
Yeah, my personal choice is not lingual. Before that, I'll prefer to take labial, and that from the lower lip. And if you don't suture it, it does not give any disfigurement. It is quite well received by the patient and does not give any cosmetic disability.
So what
labial is good.
Are you faced with the lingual graft? Why is not a lingual graft your choice? That is what we are discussing, sir. Any particular issues with it, sir?
No particular issues, but I'm not in the habit of taking lingual.
Right.
And in the spinal anesthesia, I think
taking, because we are used to taking buccal graft. That is
but spinal anesthesia, I think under local we can take buccal, but not labial. I'm not lingual. I am not happy with lingual in spinal anesthesia.
Achha, you can take buccal under spinal, you mean to say?
Yeah, if you
I have two questions.
Patients are under spinal.
Okay, fine.
I have two comments.
Dr. Bhatyal, please.
Yeah. Number one, the type of anesthesia. You know, the best anesthesia for these cases is I start with spinal epidural, keep the epidural for the post-op, and when I have to take the graft from the mouth, we just give them short GA with a nasal tube, mostly, and we can also do with the oral tube also sometimes. But local, there's a difference between institutions and the private setups. We would never take any graft under local anesthesia in the private setup. It's not a point of discussion, but for the juniors, for the youngsters also, I would not advise them. They will struggle. So please put the patient under GA to take the graft from the oral cavity and put in a epidural catheter. So the post-op is very, very comfortable these days. For most of the cases, the epidural is given. This is the type of anesthesia which we should give for all these cases.
I totally agree with the type of anesthesia, sir. Actually, I'm getting many messages, Shivam sir, on my phone that there is a practitioners forum, Jaipur practitioners forum, that has also started. So many of the people, they have to join that also. And we have gone way beyond our time. It's like 8:15. So if I think that we can ask for our faculty to give their comments and also closing comments by Shivam sir. And this is because I'm getting bombarded with messages about the other meeting that they have to go to, sir.
Yes, okay. I will give 3 comments.
Yes, please.
Number one, we must understand the difference between augmentation and substitution. Very clear. Okay. All the stage urethroplasties, majority of the cases are substitution urethroplasties unless you have used some part of the urethra. Very rarely, number one. Number two, there is a terminology which I want to add. There's a hybrid urethroplasty, that you put the graft, as Dr. Kulkarni said, on the dartos, let it take the bed supply from there and use it as a pedicled flap. That is a hybrid urethroplasty. Okay. Number three, all the residents must know the caliber of the urethra which they should be available to do what kind of urethroplasty, whether a SOPA technique or dorsolateral technique. These are very important features. Number three, whenever they are following up the patients, they have to do the uretrogram, which nobody discussed. Of course, the first presented everything. They have to be very careful. Whether you do a descending or ascending, that is up to you. I would rather like to do a descending. Why? Kulkarni will always say, no, we pass urine from above downwards. No. Whenever you pass from below upwards, you give little pressure. And that is the only pressure which shows you that there is a little leakage or not. By descending, there is hardly any pressure. He's passing urine into a tube and just passing it out. You may miss small leaks. So a pericatheter uretrogram has to be done before you take out the urethral catheter. If you find that there's an extravasation, keep it there for another week and go ahead. This is what I have to add. Thank you.
Thank you, Dr. Bhatia. Dr. Ranjan, your last comment.
I have three things to say to the resident. Now, first of all, they should know why buccal mucosa has got the #1 choice as the graft, because of its high tech. Why should it so? It is because of the rich plexus in the lamina propria level, which allows both early neovascularization and quick survival with the surrounding tissue fluid around it. Number one. Number two, in the assessment of the urethral stricture, especially for the surgery, one assessment we must do very meticulously, that is the quality of the spongiofibrosis. What is the condition of the spongiofibrosis around the urethra? That will actually guide us exactly what kind of urethroplasty we are going to give best result to the patient. And third thing, pericatheter, what Dr. Bhatia said, that pericatheteric periurethric study is no more recommended nowadays. Rather, we remove it at the third week and do a micturating history. That was only I was asking your student that how do you follow it up. That at the end of the third week, when you remove the catheter, we normally do a micturating hysterectogram to assess whether there is any leakage or not, and that should be the guideline whether the suprapubic catheter should be kept if it is placed before for the healing of that ulcer. These are the three things I like.
Thank you, Dr. Ranjan. And Dr. P.N. Dogra, if you are there, just your one comment, last comment. Dr. P.N. Dogra. Okay. So before winding up, again.
Yes, Shivam.
Yes, Dr. Dogra. Any
can you hear me?
Yes, we can hear you, sir.
Yes, thank you for asking me, because this subject is very close to my heart, and I love to hear all the discussion. And I must compliment you as a chair of the department, that your resident has done a very good job, the way he presented. And then I compliment all the faculty, the way they handled the questions and they contributed. What I have to say, that is very unfortunate that there are no defined criteria or guideline to define the success or failure of a urethroplasty. In other diseases we have, but this is a one subject. Here it all depends on the surgeon, what is our fancies and whims, and we accordingly make those criteria and say this is excellent, this is acceptable, this is not acceptable. So this is what I say. According to the assessment, yes, I agree, there is no role for uroflowmetry. The only hard assessment has to be by the way of retrograde uretrogram or endoscopy, which both are invasive, and hence we refrain to do this investigation. So what is the next then? The next criteria is only there has to be a urine flow non-obstructive. Patient should not complain that he is have to strain or apply force to pass urine. And most important, absence of the urinary tract infection. Very important. These are the only two criteria which are dependent on the patient. We rely and follow this patient. Coming to the success rate, it is not more than 70%, to be very honest. If you really talk in terms of the success of this procedure, rest they are only acceptable and manageable, and then residual is the failure. Coming to Dr. Sopa's, as you mentioned, the right terminology is transsagittal urethrotomy with buccal mucosal graft urethroplasty. That is how I think Dr. Sopa is mentioned in his original article, which none of the, I could see, nobody mentioned about this terminology. I think that is the right terminology to convey.
Ventral sagittal
transsagittal is ventral, dorsal both. It conveys. You don't have to say ventral dorsal. It conveys in one word when you say transsagittal. Okay. Then coming to whether it can be used in pan-urethral stricture. I'm sure Dr. Patel, you remember in 2004 in Lucknow Narjon conference, you were also there, one of the participants, where we presented this pan-urethral stricture, Dr. Sopa's technique, and we deliberated on this issue. So I am fan of Dr. Sopa wherever possible. I apply, whether it's a pan, urethra, whatever it is. It is very easy to handle and avoid all those unnecessary dissection. And although there are many ways to do other now later on modification you can do. This is what I think, considering the time constraint, this is what I have to add my personal viewpoint. Thank you very much.
Thank you, Dr. Dogra. So I just make 3 points here. Number one is.
Sir, आपसे पहले यादव sir again, sir.
Yes, please, Dr. Yadav.
Yeah, thank you, Shivam, and thank you, Dachi. In our part of the country, tobacco chewing is very common, and buccal mucosa is often non-usable. So I prefer prepuce or penile skin if it is not BXO case. And in my hands, preputial urethroplasty gives better results than buccal. And if the length is more, some people have a long penis and pan-urethral stricture, buccal falls short, I can add up with this. And also I use post-auricular skin, sometimes bilateral post-auricular skin whenever buccal is not usable.
Yes,
I don't know whether people are using post-auricular or not, but I am very frequently using post-auricular and gives good results.
No, we didn't discuss about the, that is the, what we call as the flap urethroplasty. We didn't discuss much.
Exactly.
But it's always an option, but because of shortage of time.
Yeah.
As he was talking about the oral problems and this and that, then preputial skin is always there.
Right. So definitely we, in the controversies, I had made that also, the flap urethroplasty, because I also agree with Dr. Anurag Yadav. And one of my preference, as Dr. Nachiket must be knowing, that in penile urethral stricture, I prefer doing a orandi flap or some kind of flap rather putting a buccal graft. And in my experience, I think the results are far better than graft urethroplasty.
No. I'm not talking about flap. It's graft. It's only graft. Preputial graft. Pre-graft.
So I'm talking about the flap urethroplasty in penile or pendular urethral stricture. So anyway, the 3 points that I was trying to make is, number one, that still there are very few randomized controlled comparative studies in stricture urethra. This has been seen throughout the world, and most of us are talking about our own experiences rather based on randomized controlled comparative studies. So probably that is which is more required. Second point that I want to make to residents also, that idiopathic stricture is still a very good part of strictures. It's almost 30 to 50% of these patients, and we must know how to prevent urethral strictures and when to which caliber of urethral catheter should be put, how long the catheter should be put, how should we care for the urethral catheter to avoid post-catheterization strictures, post-instrumentation, post-cystoscopy strictures. I think all these things are very important in our daily day-to-day practice. Third, yes, Nachiket?
Sorry. Well, I'll just make a comment after you complete, sir.
Okay. And the third point which I would try to make here is that stricture disease is usually either a stricture, which is usually a traumatic, and the second is a stricture disease rather than a stricture. So stricture disease, as Mandi has very rightly said, that the future will be a consequence of a better understanding of the disease process in a stricture urethra, rather than the different surgical techniques that we are adopting in doing stricturoplasty, particularly those augmentation urethroplasty, non-traumatic urethroplasty. So how these patients are faring because of the actual metabolism, collagen metabolism, because we know that half of these patients would not fare very well even after VIU, but half will develop a stricture. So actually, what is that stricture disease process that needs to be more researched into? Yes, Nachiket, make your point and then we'll revise.
I totally agree with you, sir, that there is a lot of data which is lacking regarding the basic etiopathogenesis at the molecular level of this disease process. And I think that also now it's time that the proper data regarding homogeneous data of stricture urethra be presented. This is because you have people who are presenting data of long anterior urethral stricture, and ultimately when you look into the paper, the average length of the stricture is just 5 centimeters. and they will present my result of 300 cases of long anterior urethral stricture, and ultimately when you see the cyst, then the length of the stricture again is just 4 centimeters. So I think that now results have to be divided based upon whether it's less than 5 centimeters, 5 to 10. Something has to be done regarding, so that data that is coming out has to be homogeneous, because we all know that the results of say a 15 centimeter stricture would not be the same as say a 4 or 5 centimeter stricture. So we need to work in that area also. And with that, I think that we can wrap up a wonderful discussion that we had. And once again, we'd like to thank all of our invitees, Dr. H.S. Bhatyal sir, Dr. Ranjan Dey sir, and Dr. Anurag Yadav sir. And a little different thing from the norm, I think that Neeraj can give a vote of thanks. Neeraj, are you still with us?
Yes, boss.
Yes.
Can you give a vote of thanks, please?
So thank you all for sparing your valuable time, sir. Dr. Bhatyal sir, Dr. Anurag Yadav sir, and Dr. Ranjan sir. Unfortunately, Dr. Kotia could not join us. So we value your inputs, and it's been a very fruitful discussion. And we hope to see you again in our further academic ventures. Thank you again, and stay safe. Good night to all of you, sir.
Thank you.
And I
Good
would just-
night. Bye-bye.
We also thank SMS Jaipur Medical College Urology Department for giving us an opportunity to speak to all of your residents and our dear friends of the society. And Professor Bhatyal, thank you very much for your.
Thank you. Thanks. I don't want to repeat the whole thing.